And this afternoon, we will have Haley Peterson talking to us. She's currently a PGY1 pharmacy resident with an acute care focus. She obtained a Bachelor of Science in Biochemistry from Utah State University, and then a Doctor of Pharmacy with the University of Utah. She's looking forward to staying on as a PGY2 oncology resident at the Huntsman Cancer Hospital with an interest in hematology and BMT. And during her time at Utah State University, she studied American Sign Language and was immersed in the deaf community and graduated with a minor. All right, Haley, go ahead. Thank you.
Thank you so much, and welcome everyone. My name is Haley Peterson, and today I will be presenting on healthcare interactions with the deaf community. So some disclosures before we start. Me and my CE mentor both don't have any relevant financial conflicts of interest, and we're not talking about any off-label uses of medications. At the conclusion of this activity, participants should be able to successfully identify healthcare disparities that exist for deaf and hard of hearing patients, propose various ways to effectively interact with the deaf community, and describe appropriate techniques when utilizing an interpreter. And for pharmacy technicians, at the conclusion of this activity, they should be able to successfully analyze the requirements to become an interpreter, compare different resources that can be utilized to increase effective communication with the deaf community, and define the importance of interpreters to communicate effectively with patients. This is just a cumulative list of all the abbreviations that will be used throughout my presentation. You guys can refer to this in the handout as we go along our way. So before I start, I would like to give a disclaimer. So I am not a deaf individual. My experience with the deaf community comes from my time at Utah State University, where I did study ASL or American Sign Language and the deaf community. The information presented today is information I collected from individuals in the deaf and hard of hearing community and from other deaf resources. I am in no way trying to speak for this community, and the information that I present today, such as effective ways to interact with deaf individuals, do not apply to all deaf individuals. It's important to personalize care for each patient, which should be our standard no matter kind of what language our patient uses. Special thank you to the Utah State University and University of Utah Deaf Clubs, the Salt Lake Community College Deaf Organization, the Utah Schools for the Deaf and Blind, and the Division of Services for the Deaf and Hard of Hearing, specifically the Sanderson Center. They were very great resources while I was putting together this presentation. So before we jump in to this presentation, I think it's very important to know the difference between deaf with a capital D and deaf with a lowercase d, as you're going to see this throughout my presentation. Deaf with a capital D refers to a deaf person and the community they are a part of. It is how they identify. Deaf with a lowercase d refers to the medical condition of deafness or being unable to hear. So the deaf community and the utilization of ASL or American Sign Language is actually quite vast in the United States and in Utah. The 2022 US Census estimates that about 3.5% or about 11.5 million Americans identify as deaf or hard of hearing. And American Sign Language is the third most utilized language in the United States after English and Spanish. A 2022 study estimates that adult ASL use is about 2.8%. However, this includes individuals that are deaf, hard of hearing, and hearing individuals who use ASL. So it's kind of hard to get a full estimate. Specifically in Utah, we do have a higher percentage of deaf and hard of hearing individuals than the average in the United States, with an estimate that about 5.6% of our population, or about 187,000, are deaf or hard of hearing. So it is a very big population that we will serve in the state of Utah. So now we will discuss healthcare disparities that deaf and hard of hearing individuals face. So something I find really interesting is that studies dating back to the 1980s discuss healthcare disparities for deaf and hard of hearing patients. However, while they've been identified that long ago, nothing has really changed since then. We are still facing the same disparities, or the same disparities are being faced today. One of the main causes of disparities is the lack of effective communication. And effective communication between a healthcare professional and a patient has been called the heart and art of medicine. So it's very vital. Lack of effective communication can drastically impact patient health. And a study conducted at 20 Quebec hospitals showed that preventable adverse events were significantly more likely to happen in patients with a communication barrier, with an odds ratio of 3. A few other studies that I want to highlight, specifically in a deaf community, include a 2004 study that found that 77% of ASL users had difficulty communicating with the hospital staff. 33% left PCP appointments unsure about instructions about their disease or their medication. And then 30% just avoided seeing their PCP altogether because of communication difficulties. A 2011 study in the UK compared different health markers between deaf adults and hearing adults. It found higher rates of obesity, hypertension, and hyperlipidemia in the deaf population. For patients with hypertension that were being treated with medication, a lower proportion of them had a blood pressure less than 140/90 compared to hearing adults with hypertension that were being treated. Additionally, more deaf adults with hypertension were unaware of this diagnosis as it has never been effectively communicated to them. And for patients with high cholesterol, only 31% of deaf adults were on a statin compared to 79% of hearing adults. Additionally, deaf individuals were 5 times more likely to report attempting suicide in the past year and about 2 times as likely to have a mental illness, but less likely to receive effective care. So in preparation for this presentation, I was able to set up a couple of interviews with some deaf adults. And the 2 main questions I asked them was, what has your experience in healthcare been? And what changes would you want to make in healthcare? So the words presented on this slide summarize some of the repeated themes that were mentioned during my interviews. These include that they felt like a burden to the healthcare provider and the healthcare system. They felt like a burden asking for an interpreter to be present during their appointment. And they felt like a burden if they had to call before their appointment to verify that an interpreter would in fact be there. They felt it was a burden if they had to ask clarifying questions to a provider, so they usually didn't. Overall, they felt like the medical staff they interacted with was just really impatient with them. And overall, they expressed a lot of distrust with the healthcare system as they have experienced frequent misunderstandings, either misunderstanding when they are explaining their symptoms or misunderstanding of their disease states and or medications. And from this interview, I have 3 stories that I would like to share with you with permission from the people I interviewed. So the first one is a patient was misdiagnosed. They did not have an in-person ASL interpreter when they went to an urgent care, so they weren't able to fully express their symptoms, were misdiagnosed, ended up having pneumonia, and they were prescribed the wrong medication, and 2 weeks later had to go to the hospital and get IV antibiotics. The second is a female patient went to her annual physical and needed to get a pap smear. However, the physician never explained what was about to happen. And so they put him on their gown and they laid down. And then the physician went out of sight and the pap smear was performed with no communication to the patient. And they did not know what was happening and they just weren't expecting that. And to this day, they remain anxious about going to appointments. And the third is a patient was waiting in the waiting room, but they weren't looking at the door where the MA was coming out. So they didn't see a person come out and call their name. And because they couldn't hear their name be called, they completely missed their appointment despite being present for it and were marked as a no-show. So in addition to those personal stories that I was able to get, I was also able to compile a couple articles. The first one is to show the impact on preventative services. And it was a cross-sectional study specifically done in Rochester, New York, as Rochester, New York has a high deaf population. And it was looking between the association between the participation's communication method, so if they were able to effectively communicate with their provider, and if preventative services were offered. The 3 preventative services that they specifically looked at was if they had an influenza vaccine in the past 12 months, if they've ever had a colonoscopy for cancer screening, and if they've had their cholesterol checked. And this study included 89 deaf patients between the age of 50 and 75. And the results found that participants who were able to communicate in ASL either directly to their provider or through an interpreter were more likely to receive these preventative services with an odds ratio of 3.42. And this was even after adjusting for other social determinants of health, which might affect this. Specifically, the highest preventative service that was offered in patients that were able to effectively communicate was the flu vaccine. And this odds ratio was 4.55. So another study was done actually at ISU, Idaho State University, and it was done in 2018. And they did this simulated call method where they assigned 4 hearing patients and 4 deaf patients to call a list of both primary care centers and dentist office to see if they could make a new patient appointment. And they went through a list of questions and they just were trying to see if they could schedule an appointment. So they tried to get rid of any confounders by having each person follow a script. There was a total of 329 clinics, and to be deemed successful, they had to make an appointment. And for the deaf patients, they had to make an appointment and get verification that an interpreter would be there. And as you can see, the hearing patients were successful 64.4% of the time, whereas the deaf patients were successful 49.1% of the time. So a very big difference in the rate of success with an adjusted odds ratio of 1.88. And then of the deaf adults that were unsuccessful, 48.2, so about half of the ones that were unsuccessful, was associated with a request for interpretation. So that's why they were denied a new patient visit. Another study that was conducted looked at the community pharmacist's comfort level and what communication methods they use to interact with their deaf and hard of hearing patients. And it was a cross-sectional study utilizing a questionnaire. They had a pretty low response rate, which is pretty common with questionnaires. They had about 30% of community pharmacists that responded. But I think even the 30% that responded, the results are still very telling. They found a higher comfort level in community pharmacists that received at least 1 prescription for a deaf or hard of hearing patient. So if they were seeing it more, or if they had a prior experience interacting with a deaf or hard of hearing individual. And they had a significantly lower comfort level if they thought that sign language was a necessity for them to interact with these patients. Interestingly, about 90% of them used written information, whereas only about 3.4% of them used a qualified interpreter. The last study we'll talk about was a study looking at the effect of effective medication counseling or education done in a patient's language or ASL by pharmacists. And so what they did is they hosted a medication education class that was specifically taught in ASL, and they were provided slides and handouts, and they provided the deaf and hard of hearing patients with a questionnaire both before and after this class was presented. And it was asking things about knowledge of medication use and attitudes regarding the explanation. And to compare, they also gave this questionnaire to 20 hearing patients, but they did not take the medication class. And as you can see, the number of correct answers before and after the medication education class drastically increased in the deaf population. It went from 8.5 correct answers to 16, which really just shows the impact that effective communication can make for patients. So guidance for healthcare professionals. How can we effectively interact with the deaf community? So the NAD, or the National Association of the Deaf, actually has guidelines for healthcare professionals. They talk about clearly identifying at-risk individuals who may need interpretation services. So putting this somewhere very easy to see on a patient's chart. That way, when you are working up a patient or checking in a patient, you can see that they require interpretation services. Include things like visual medical aids like charts or diagrams. Also include online resources that can help reinforce teaching when the patient leaves. They really caution providers that know basic sign language. They encourage you to be aware of your limits. Knowing American Sign Language is very different than being proficient enough to be able to sign in a medical environment. If you can remember when you were training and learning medication names and lab tests, it's a whole other world. And so that's not what's usually taught in American Sign Language classes. So it's good to be aware of your limits and realize that you need an interpreter who is specialized in medical sign language. And if bilingual staff members are used as interpreters, they should be assessed by an accredited body prior to providing services. And then you need to establish an effective communication office policy. So frontline staff should ask deaf patients what their communication needs are and document this in the medical report. More guidelines from this include providing qualified interpreter services. Like I mentioned before, medical sign language is not just basic sign language. So your interpreter should be familiar with medical terminology, but also the healthcare provider should avoid any medical jargon or acronyms. And then realize that deaf individuals may vary with their preference of types of sign language or signing styles. There's American Sign Language, there's English-based sign language, and tactile sign language as a few examples. And you may need to use a certified deaf interpreter or a CDI. And a CDI is a certified interpreter who is also deaf or hard of hearing, and they work in tandem with an American Sign Language interpreter. And this type of interpreter is used if someone knows if the patient uses a foreign sign language, or if they use a version of like their home sign language that's not necessarily American Sign Language. So it's just to help bridge that gap. Avoid using the patient's family or friends as interpreters, and then look and talk directly to the patient, not the interpreter, but realize that the patient likely won't be looking at you, they will be looking at the interpreter. And then do not assume that talking loudly will help increase understanding. The NAD goes on to say some ineffective methods of communication. So lip reading is frequently ineffective. Most sounds cannot easily be read on the lips. And in COVID, we have masks on, so lip reading could not be relied on. And about 30% of English is readable on the lips. So patients are not going to be grasping a lot of what you're saying just because it's very hard to read lips. And do not assume note writing or writing back and forth is an effective communication tool. American Sign Language is not based on written or spoken English. It is a separate language with its own grammar rules. And English is often the deaf patient's second language. So don't assume they are fluent in English. And writing is labor intensive and may be inefficient in a medical setting. So the NAD is also able to provide training to hospitals and medical centers that are interested by just going to their website. So to kind of show the difference of time when you're writing out a conversation versus using an interpreter, I did a little experiment where I had a couple of friends play out this really basic script with me. And one of the ways we did it is we wrote back and forth. And then the other way, we used a friend as an interpreter and we had the same conversation. And as you can see, the conversation when we wrote out every single word this conversation took 3 minutes and 25 seconds. Whereas when we used an interpreter, it took 1 minute and 23 seconds. So it was about double the time to write it out. And this is a very short and sweet conversation. Imagine the length of time explaining an anti-coag medication would be to a patient, something a lot more intense than this conversation. So there's another source that provides guidelines for healthcare professionals, and it's the Royal College of Physicians, and they call it their AEIOUs. So the A is ask, how does the patient wish to communicate? And then do their notes or health records indicate their preferred language? Do they have any hearing aids or cochlear implants? And are they working or are they on? Is there a cognitive barrier that needs to be assessed? E is environment, so minimizing background noise. Make sure the interviewer face is well lit and unobscured, and make sure you're dedicating time to the consultation. I is interaction, use an interpreter when possible, and make sure you're addressing the patient, not the interpreter. Outline, prepare the patient for the topic of conversation, and make sure when you're changing topics, it's very clear. And then understanding, check patient comprehension and ask for periodic summaries or teach back, and then repeat or rephrase unclear information. Overall, I think these AEIOUs are great, but I also think they apply to every patient with maybe the exception of the interpreter if you're talking to someone that speaks the same language as you. But at the end of the day, this is how we should be interacting with patients. From my interview with individuals at the Utah School for Deaf and Blind, the advice they had for healthcare professionals can be summarized on this slide. So the first one is have 24/7 access to interpreters and have many different licensed interpreters on call. Don't just have one person that might not be able to get into the hospital. And if that's not possible, at least have a video relay imaging option, which is like a two-way communication method where it has a kind of virtual interpreter for the person that needs sign language, and then it has someone talking to the hearing person. And these patients don't want to have to advocate so hard to get an interpreter. It should just be, oh, you're deaf and you speak ASL, of course we'll get an interpreter for you, because that is the language that you use. Education, educate healthcare professionals on interpreters, what they are, what they do, how they become licensed, and their role in the healthcare setting, which I hope that this presentation is doing. And then realize that deaf patients may bang on the table or flicker lights to get the attention of a healthcare professional. They're not being rude. That's just how they get your attention. And also realize that that's something you might need to do in order to protect a patient's privacy. For instance, if a patient is in a hospital bed, realizing that knocking on the door before you enter isn't really going to do anything. So open the door, flick on and off the lights, and then proceed all the way in. That way you're alerting them that you're going to be coming in for privacy. And realize there's a large variety of deafness and hearing loss, and not all patients are the same. And the last one was attitude. Stay calm. Miscommunication can easily lead to frustration, anger, anxiety, etc. And this is usually when the deaf patient said they would just kind of stop asking questions, be ready for the appointment to be over, even if they had no idea what was happening. And then don't treat deaf and hard of hearing patients as annoyances simply due to their hearing loss. And realize that being deaf or needing an interpreter does not mean they are helpless or unable to take care of themselves. I really want to highlight the St. Alphonius Medical Center in Idaho. They created a Deaf and Hard of Hearing Advisory Council in response to that 2018 ISU study that did the simulated patient phone calls. And their goal was to promote better access to healthcare, effective communication, accurate assessments, diagnosis, and treatments, and improved patient-provider satisfaction and trust. And in this council got together and discussed what they should do, and this is what they implemented. So the VRI, or the video relay, with bedside interpreters, and they also provided a deaf and hard of hearing kit to all deaf and hard of hearing patients on admission. And they would provide annual training about cultural and language differences and how to access their specific hospital resources. They also brought in deaf educators to teach childbirth preparation, breastfeeding education, newborn care, and parenting classes taught in ASL. So the deaf and hard of hearing kits that they provided for patients included things such as patients' rights and responsibilities, the medical professionals' responsibilities when working with deaf and hard of hearing patients, tips and ideas that can be given to the healthcare team in ways that they can best communicate with deaf and hard of hearing patients, pictures such as bathroom, chest pain, etc. In case communication needs to happen ASAP. This is not what you should rely on for your communication, but if a patient really needed to express something in an emergency before an interpreter, either in person or virtual, could be before you could get one, if they needed to communicate. And then cards to place above the patient's door or above the patient's bed and on their door that tells you that they are a deaf or hard of hearing patient and provides the instructions to flicker the light when you enter the room. And then tips and strategies on how to contact an interpreter in that facility, plastic bags or containers to hold hearing aids or cochlear implants so they don't get lost. And then helpful tips for staff regarding hearing aids and cochlear implants. That way they don't get broken, and a visual pain scale. I also want to just highlight all of these resources for healthcare professionals. I'm not going to go through them all, but I do want you guys to know that there are a ton of resources for healthcare professionals when interacting and taking care of deaf patients, and they even break down more than just overall deaf patients. So interpreter services, let's talk about interpreters. So federal laws. So it is a federal law to provide an interpreter for a patient. Specifically, there's the Rehabilitation Act of 1973. Section 504 mandates equal access for all federal healthcare services and facilities. And then the Civil Rights Act of 1964 mandates appropriate access in healthcare settings to individuals who have limited English proficiency. And the Americans with Disability Act has two different titles. One requires equal access to all public healthcare professionals, and then the other one mandates equal access to all private healthcare providers. So basically, every healthcare provider should be providing interpreter services. However, there is a loophole in the Americans with Disability Act that sometimes is used in order to get out of that. And the loophole states that unless the public accommodation can demonstrate that taking those steps would fundamentally alter the nature of goods, services, facilities, privileges, advantages, or accommodations being offered, or would result in an undue burden, such as significant difficulty or expense. So this loophole is sadly used a lot in order to not provide interpreter services for patients. And an example of this loophole being utilized comes from the Atkins versus St. Helena Hospital. So Mrs. Atkins alleged that the provider failed to communicate effectively with her during her husband, who is now deceased, medical treatment. She requested an interpreter. Both her and her husband were deaf, and she requested an interpreter multiple different times. The interpreter they provided for her only knew how to finger spell. So that is spelling out each individual word, which I imagine could take a very long time. And Mrs. Atkins' daughter arrived a few days later and became the interpreter. And the St. Helena Hospital reported that providing the finger speller and providing adequate medical care was compliant with the ADA requirement. And what I thought was interesting was the court decided that adequate medical treatment is not a defense to a claim that a physician has failed to provide effective communication. So even if you perfectly treat your patient and you cure them, that is not a way to get out of effectively communicating with them. So I think that's important to remember. There are different types of interpreters. I specifically pulled these from the state of Utah. So there's Utah professional certifications, individuals who are able to facilitate communication in most situations, including complex, technical, or specialized situations, which would be like a hospital setting or a medical setting. And then a Utah novice certification, so more entry-level skills and knowledge in a variety of situations, excluding the more complex and technical. But these interpreters must advance to professional within 4 years. And then the Utah Certified Deaf Interpreter, or CDI, which we talked about before, which is a certified interpreter who is also deaf or hard of hearing, and they work in tandem with an American Sign Language interpreter. And then Educational Interpreter Performance Assessment, or EIPA. These are interpreters that have demonstrated skills in specialized settings, specifically elementary and secondary schools, and modes of communication such as American Sign Language or Pidgin Sign Language, and they are restricted to work in a K through 12 educational setting. So they are more specialized to schools. So how do you become an interpreter in the state of Utah? So we have a Utah Interpreter Program, or a UIP, and they are responsible for certifying and regulating ASL interpreters in the state of Utah. And they maintain a directory, so you can visit their website and find a directory of all certified interpreters in the state. They also offer state certification exams and recognized certification exams that are national. So if someone moves to Utah but got a national certification, that is still verified in the state, and certifications must be accepted by the Interpreter Certification Board. So the Utah law and policy that governs interpreter services is Title 35A, Chapter 13. And basically it just says that individuals are required to be certified as a certified interpreter, and that you have passed a certain amount of tests and skills, and that you will be issued a certificate in order to be able to be an interpreter. So interpreter licensing exams. So the first exam they will take is a Utah Certification Knowledge exam. So it's a 100 multiple choice exam. And I put the breakdown of the exam on the right. So 40% is ethics, 20% is interpreting, 20% is culture, 10% is ASL and English language, and then 10% is history and laws. And then after you pass that test, you must pass a Utah Certification Performance exam, where you're actually kind of interpreting in your exam, and you measure the ability to interpret in various situations. So interpreter services in Utah. So I compiled some examples from the big healthcare organizations in the state of Utah and put them on this slide, but definitely check with your organization about what interpreter services you guys have access to. In the state of Utah, we have the Division of Services of the Deaf and Hard of Hearing, which has the Utah Interpreter Directory. So just a list of everyone that is certified as an interpreter in the state of Utah. And they also have links to different interpreter agencies that they have verified as certified interpreter agencies. The University of Utah uses in-person interpreters from 5-Star Interpreting and Interwest Interpreting, so just different agencies. And then we also have the MARDI system on the iPads. Intermountain also has on-site interpreters, and they use 5 different agencies, kind of just depending on region. And then every floor and clinic has iPads with access to ASL interpreters. But you might be thinking, if you don't work in a super big hospital center or you work in a community pharmacy and you don't have access to these agencies, don't fret. There is a free service, and it's the Free Video Relay Services, or VRS. And in the 1990 ADA Act required the Federal Communications Commission to develop and enforce a relay service regulation. And then this was updated in the 21st Century Communication and Video Accessibility Act, which established new protections due to new technologies. These relay services are provided for free. The FCC oversees the Interstate Telecommunications Relay Fund. So if you use this as a community pharmacist that maybe doesn't have access to one of the bigger agencies, this is a free resource. And many options are available. There's a TTY relay service, and this can be reached by anyone by dialing 711 from a telephone or a TTY device. And then VRS, which is internet-based, and it allows conversation to flow in near real time, and it's kind of more it's faster and more natural. So it's kind of like FaceTiming with an interpreter. So some tips and tricks when utilizing an interpreter. Look and speak directly to the patient, not the interpreter. Use your ordinary language and speaking style. Don't speak super fast. Don't speak super slow. Avoid phrases like tell her or explain to him, because you are talking to the patient. Don't ask the interpreter to refrain from interrupting or interpreting something for you. They must interpret everything you said. They can't just pick and choose. Provide appropriate lighting, realizing that American Sign Language is a visual language. So you want your patient to be able to see the interpreter, and position the interpreter so they are in the line of sight of the patient. And if you're in a group discussion, permit only one person to speak. That way the interpreter can effectively translate what is being said. And then overall, the individuals I interviewed basically just said, relax. If you're unsure of the appropriate way to proceed in a particular situation, just ask. There's no shame in just asking, what is the best way I can communicate with you, or how do I do this? It's better to ask than just not do. Okay. I think that takes us. Yeah, okay. I was making sure I didn't click through too many. So we will switch to poll everywhere. Okay, and the first question is, which of the following are true statements regarding healthcare disparities in the deaf and hard of hearing population? And this is a select all that apply. So looks like a pretty good split, and all of the answers are correct. If you remember from the 2004 study that looked at the preventable adverse events in the 20 Quebec hospitals. It did find that preventable adverse events such as medication errors were significantly more likely in patients that had a communication barrier with their provider. Deaf individuals were 5 times more likely to report attempting suicide in the past year, and deaf patients do have a higher rate of hyperlipidemia, yet are less likely to be on a statin than a hearing patient, and that comes from the UK study. Okay, so the next one is a patient case. So which of the following would be the most appropriate way to counsel the patient regarding their discharge antibiotic? And the patient case is LH is a 27-year-old male who is deaf and requires an ASL interpreter. LH is admitted to the hospital for an infection. The patient has been adequately treated and is now being discharged home with a prescription for an antibiotic. You are going to complete the discharge counseling on this antibiotic, but are unable to get an in-person interpreter. So what is the best way to proceed? Okay, I think the results have stopped coming in. So 95% said C, which is the correct answer. So if you can't get an in-person interpreter, the next best option would be obtaining an iPad or a tablet and utilizing a virtual interpreter. That way an interpreter is still being utilized to complete the education. A is incorrect because relying on the patient to read your lips is very ineffective. Only about 30% of the English language is able to be read off the lips. And imagine trying to say antibiotic names that the patient is not familiar with and expect them to be able to read that off your lips would be very hard. B is incorrect. If taken the antibiotic and print off containing all the counseling points and just give to the patient to read. Again, English is these patients' second language, and don't assume that they are efficient in reading English because that is not their first language. And then D is incorrect. So provide counseling using your very basic ASL skills, relying on a lot of finger spelling. Again, it's good to know where our limitation is. It's amazing if you know American Sign Language, but unless you are a certified medical interpreter, you should not be interpreting for your patient. And imagine trying to spell out amoxicillin clavulanate with your finger spelling. That would be a lot. And then in addition to all the other counseling you would provide. So the next question. So which of the following is not an appropriate technique to utilize when using an interpreter? Okay, so majority said B, which is the correct answer. So which of the following is not appropriate? So it is not appropriate to look at the patient. That part's appropriate. But making sure they make eye contact with you is the part that makes that not appropriate because they will be looking at the interpreter. A is an appropriate way because you are supposed to speak directly to the patient. That is who you're conversing with. The interpreter's there just to help the communication barrier. C is not an appropriate, or C is appropriate because you want to make sure the room is well lit and position the interpreter so that the patient can see them. And then if you are in a group setting, make sure only one person is speaking at a time. That way the interpreter can effectively translate. Okay. The next question is true or false. According to Utah law, certified interpreters need to pass a written and performance examination. 100% said true, which is correct. You have to pass the 100 multiple choice written exam, and then you have to complete a performance exam, which I think is appropriate because you want to make sure that you can actually communicate in ASL. B is not true because it is true. So the next question is, how can you reach TTY relay services? Majority of you put C, which is the correct answer. So from a telephone or from a TTY device, you will just dial 711 and you will be connected to the interpreter services. A is incorrect because you would dial 711. You don't have to go to an app. B, the NAD website does provide information on how to set up a call, but you don't go there to set up the call. And then D, TTY services do exist, making D incorrect. So the last question I have is true or false, the ADA encourages use of patients' family members and or friends as interpreters as they are closer to the patient and will be better they will be better to explain diseases and medications to the patient. So the answer is false. So kind of with any time you're using an interpreter or need to talk to someone in a different language, it's never preferred to use a family member or friend. Realize that the patient's privacy is of utmost importance, and just assuming that using a family member or friend is preferred would be breaking that privacy. So it's false. You should be using a certified interpreter. Awesome. That is all the whole everywhere questions. Let me go back to my PowerPoint.